Good morning. Okay, so I know I need to get to the slide that has, let's see. There's the code. Leave it up there for a second. Anybody else? Okay. So today I'm going to talk about some common psychiatric disorders that may onset or worsen following metabolic and bariatric surgery, or MBS. And talk about a plan for measuring and managing mood symptoms, including suicidal ideation that may present post-surgery. And then I'm going to talk a little bit about identifying risk factors of new onset or recurring substance use disorder post-surgery. So just as a review, here are 3 common MBS procedures. We have Roux-en-Y gastric bypass. I usually refer to this as gastric bypass or bypass during the talk. And so what happens is a small portion of the top of the stomach is cut away, and the small intestine is connected up to that small portion. That now becomes the patient's stomach. And then the old stomach, remains in the abdominal cavity and is connected downstream to the small intestine so that digestive juices can still flow in there. The most common surgery today is the one in the middle, the sleeve gastrectomy, in which 70 to 80% of the stomach is removed completely, leaving the patient a stomach about the size and shape of a banana. And then we have the endoscopic sleeve gastroplasty, kind of the new kid on the block, if you will. An endoscopic suturing device is placed into the patient's stomach, and they staple an amount of the stomach so that the volume left is similar to what's present for the sleeve gastrectomy. Okay, so gastric bypass produces very durable weight loss. What you're looking at in this graph here, we have percentage total weight loss on the y-axis and time up to 20 years on the x-axis. Patients lose a significant amount of weight, up to about 30% of their total body weight within the first year or so, and typically do pretty well at keeping that weight loss off over time, although as you can see there is some good variability, especially as the further out we get. There's also, in addition to weight loss, remission of comorbidities such as type 2 diabetes, hypertension, and sleep apnea that also help improve the patient's health. When we compare weight loss outcomes between the gastric bypass and the sleeve gastrectomy, so just to orient you, on the y-axis we have percent expected body weight loss, and on the x-axis we have time. The circles are sleeve gastrectomy patients, and the squares are Roux-en-Y gastric bypass patients. You can see the bypass patients tend to lose more weight and have less variability in weight loss outcomes over time. Patients who undergo sleeve also see improvements in their comorbidities. Of course, it's important to note that if patients regain a large amount of weight, often there is a recurrence of those comorbidities like sleep apnea, hypertension, etc. And then for endoscopic sleeve gastroplasty, we don't have a lot of weight loss outcomes yet. What you're looking at in this graph, I'll have you focus on the orange bars, which represent total body weight loss. It's about 15 to 18%. However, we only have 3 studies that go beyond 2-year outcomes, so really need to do a lot of work here. But it's becoming increasingly popular, and I think it's probably going to increase in popularity because it is less invasive. So hopefully what I've shown you at this point is that bariatric surgery can help patients improve their health pretty significantly. However, there are some concerning psychiatric symptoms that either onset or recur after bariatric surgery. I'm going to talk about those today, starting with eating disorders. So full syndrome anorexia nervosa or bulimia nervosa are quite rare after patients undergo surgery, but not totally absent. What we see with restrictive eating disorders is more of an atypical anorexia presentation in which patients have lost a significant amount of weight, but their weight remains in the normal or just above normal range. These patients have developed a fear of fatness. They are often terrified of regaining their weight and becoming ill again. They often have vitamin deficiencies and are at risk of developing Wernicke's-Korsakoff. In terms of bulimia nervosa, the full syndrome is rare because binge eating is quite difficult due to the altered anatomy post-surgically. Over time, binge eating becomes a bit more common, as you'll see. In terms of what we see with vomiting, patients will sometimes vomit, or they tell us they're vomiting not in the service of weight loss, but because of something called plugging. If patients don't really eat their food or chew their food very well and kind of get it to a liquid consistency, can kind of stack up and feel, they get this sensation that the food is stuck in their throat or their esophagus, and so they may vomit to alleviate that sensation. Another presentation we sometimes see is patients say they don't induce vomiting, but they might eat so much that they spontaneously vomit because their stomach can't hold that much. So that people know, we do have a nutritional protocol specific to patients who have had bariatric surgery that can be implemented on the Meyer 4 Eating Disorder Service here at Johns Hopkins. It was developed by Dr. Angela Guarda, the director of the program, and Allison Pletch, a clinical nurse specialist. We published a case series of patients who've been treated on this protocol, and it was found effective for patients both on the weight gain and weight maintenance protocol. The majority of patients were discharged for clinical improvement. One notable finding of that study is that the majority of patients had had an eating disorder before they underwent surgery. The majority didn't disclose it, and almost none of them had had treatment, which I really think speaks to the need to making sure we're managing these symptoms post-surgically and trying to get our patients to talk to us about them. And then the final thing I want to say here is that we need to be very careful when we assess eating disorder symptoms post-surgically, because it is often difficult to distinguish a patient with disordered eating from someone who is carefully following the post-surgical dietary recommendations. And I think one of the best distinguishers is that patients who have disordered eating don't recognize how serious their behaviors are and will not make changes even when urged to do so by their physicians. So typically when a patient presents with binge eating at the pre-surgical psychosocial evaluation, we refer them to treatment before they undergo surgery. However, there is some evidence that surgery alone can reduce binge eating disorder. And so what you're looking here at this chart here is data from the longitudinal assessment of bariatric surgery, which was a large study of 2,400 patients followed for up to 7 years after surgery. You can see in the far right column, the percent with binge eating disorder pre-surgically was 12% and reduced to just 1.3% the following year, and went up to around 3.5% at most over that 7-year follow-up time. So we do see these reductions. Again, though, the capacity to binge eat is quite low post-surgically. We also see that loss of control eating, in which the patient experiences loss of control but are not necessarily eating a large amount of food in one sitting, is pretty prevalent. It's at just around a third pre-surgically and stays somewhere between 20 and 30% post-surgically. One thing to highlight, although we do see remittance of binge eating disorder in the patients remitted from binge eating disorder in this study, almost half of them reported loss of control eating, which I think again highlights that maybe just the presentation shifts post-surgery. The most common post-surgical problematic eating behaviors are loss of control eating, which I just discussed, night eating, and graze eating. Loss of control eating and graze eating are both associated with poorer weight loss post-surgery. And again, we really think that that graze eating, sometimes called picking or nibbling, is often the transitional behavior for patients who are binge eating post-surgery. So we want to keep a close eye on that. Treating post-surgical binge eating disorder or loss of control eating is difficult because we just don't have good guidance. There haven't been a lot of studies telling us just what to do. There are a few new treatments. There's something called post-bar, which is an intervention for patients who have binge eating and depression after surgery and uses CBT. There's also a brief 6-week cognitive behavioral therapy intervention delivered via telehealth. However, only pilot studies have been done with these interventions. They look promising, but we need more work to be done. There was one large randomized controlled trial for patients who had loss of control eating symptoms post-surgery. It compared a guided self-help CBT to a guided self-help behavioral weight loss intervention to treatment as usual. And they followed the patients for 2 years. There were no intervention effects. All of the patients have reductions in loss of control eating regardless of what they were assigned to. and lost a similar amount of weight. And so what I'm going to ask next, because most of these studies of post-surgical eating disorder, the outcome that they're most interested in is weight loss. And I appreciate that, right? We know that higher weight is associated with worse health outcomes. But I'm wondering if it should be the outcome in treatment studies for patients who have eating disorders post-surgery. This chart here on the right, because there were kind of no intervention effects, they collapsed and compared individuals who had abstinence at the end of treatment from loss of control eating to those who didn't. The abstinent group is the white bars. There were no differences in weight loss, but the patients who had abstinence from loss of control eating reported lower overall eating disorder symptomatology, so lower weight and shape concerns, lower dietary restraint, and they also had lower depression scores than those who were not abstinent at the end of treatment, and these continued for up to 2 years. There's a large body of evidence that indicates that dietary restraint, caloric restriction, may increase the likelihood of relapse of binge eating behaviors. And so I think it may behoove us to consider whether or not we should help our patients continue to diet if they have this history of disordered eating, or if we should focus on some of these other psychosocial outcomes and weight maintenance and focusing on their health in that way. I'm going to shift to talking about mood disorders now. After bariatric surgery started to happen, people were very interested in whether or not it helped reduce mortality rates. And so a large study was conducted using the Utah population database. They compared individuals who underwent surgery to age-matched controls and looked at death rates over time. As expected, individuals who underwent MBS had lower all-cause mortality. They had lower mortality rates due to cardiovascular disease, cancer, and type 2 diabetes. They were surprised to find, however, that patients who underwent bariatric surgery had higher rates of death due to accident, poisoning, and suicide compared to those age-matched controls. And this led to increasing research on this. A follow-up study was conducted and published in 2023. This was a larger group of individuals. It also had people who hadn't just undergone gastric bypass. It had everybody who more surgical types, and they were able to stratify the data by age and gender. The findings were repeated. Patients who underwent bariatric surgery had higher death rates due to suicide, poisonings, etc. And the age risk at highest risk of suicide were those who are 18 to 34. As I mentioned, a lot of interest in suicide after bariatric surgery has prompted a lot of research, and a recent meta-analysis found that patients who underwent bariatric surgery were 4 times more likely to complete suicide versus the general population. And this is particularly concerning because individuals with obesity tend to have lower rates of completed suicide versus those without obesity. Suicides are typically occurring 18 to 60 months after surgery. And there also is a higher incidence of accidental deaths in individuals who undergo bariatric surgery, which may suggest that we could possibly be undercounting the suicide rate. Risk factors observed among those who have completed suicide are male gender, history of mood, anxiety, and substance use disorder, psychosis, impaired sleep, and a history of non-suicidal self-injury or suicide attempt. There's also an increased risk of non-suicidal self-injury. A large study done in Canada of about 8,000 patients found that females were more likely to engage in NSSI, as were individuals ages 35 to 65 with lower SES from rural areas. Notably, having a history of anxiety or depression was not associated with increased risk of NSI. We do see that suicidal ideation decreases after surgery and then returns to pre-surgical levels. And some of the predictors of post-surgical suicidal ideation are pre-surgical suicidal ideation and self-harm, male gender, smoking, pain, and being on an antidepressant. So it's not quite clear why we are seeing this increased risk of suicide in patients who undergo bariatric surgery, but there are a few proposed contributors. First is weight regain or recurrence of comorbidities, or even if patients don't see benefit in terms of physical or health-related quality of life post-surgery. Many of our patients see bariatric surgery as their last hope for improved health, for an improved lifestyle. And when that does not materialize, it can be quite demoralizing. Often patients can feel hopeless, and I think that this may play a role in the increased rates of suicide that we see. Impulsivity is also elevated in individuals who have obesity. And as I will talk about in just a few minutes, we also see changes or increases in alcohol use, and these two factors combined together may be playing a role. There's been some preclinical studies looking at changes in gut hormones like ghrelin, GLP-1, PYY, as well as changes in gut microbiota or bile acids in animal studies that have shown changes in anxiety or depression, as measured in rats, of course. This is quite theoretical at this point, but it could be playing a role here. And then, of course, pre-surgical mood disorders. Psychiatric comorbidity is very common in individuals who undergo bariatric surgery. And although we do see improvements in mood in that first year post-surgery, the improvements wane over time, and it's very likely that patients are going to have episodes of depression or mania post-surgery. There also can be pharmacokinetic changes affecting absorption of psychotropic medications. Up to 40% of patients are taking an antidepressant at the time of surgery, and so this is certainly an area to consider. And that is why I'd like to draw your attention to a review paper that was recently published by one of our colleagues, Dr. Janelle Coughlin. And I think this paper is excellent and should be perhaps required reading for anyone who is providing psychiatric medications to patients undergoing bariatric surgery. And what I'm going to do is try to summarize some of the key recommendations that came out of this paper. So the first one is be suspicious. If a previously stable patient is now developing symptoms, it could be that the drug is just not metabolizing well due to changes in the pH level in the gut, changes to gastric motility, changes to enzyme availability. And they really say that measurement-based care is indicated. If the medicine has a clear therapeutic level, you could do serum concentrations. For medications that don't have defined therapeutic ranges, you can consider changing the dose or the formulary. And if you're particularly concerned about a patient, a trough serum concentration level could be taken before surgery for comparison after surgery. And although I think it's kind of in the lore that we should be avoiding extended release medications, the researchers, the authors of this review said, we just don't have good evidence to make those changes, and it should be done on a case-by-case basis. They also highlight that there might be unintended consequences to making these changes, especially right before surgery, right? So one of the benefits of extended release medications, they can be taken less often, they may be better tolerated in that extended release formulation, and making that change could affect compliance, especially because there's a lot going on in that perioperative period. A third recommendation is to beware of medications that are weight promoting or that may worsen metabolic outcomes. For antidepressants, TCAs and MAOIs have the highest risk, whereas SSRIs have lowest risk. For the mood stabilizers, carbamazepine has the lowest risk. Lamotrigine and topiramate are considered weight neutral, and lithium and valproic acid have the highest risk. For the antipsychotics, aripiprazole and ziprasidone have the lower risk, and quetiapine, risperidone, and olanzapine have higher risk in terms of weight gain. However, they stress that making sure patients' mood symptoms are well managed trumps any weight concerns. A fourth medication is to monitor lithium levels pre and post-surgery to prevent lithium toxicity. And the fifth is with respect to SSRIs. There is an increase, SSRIs may increase the risk of internal bleeding during the perioperative period. They stress that a change is not necessary to make, but something to make the patient aware of. And also for SSRIs, discontinuation syndrome may occur post-surgically, something to watch out for. So in summary, with respect to the mood and suicidal risk, we should be assessing patients' moods I actually recommend a lot of my patients keep a daily mood diary for the first 3 or 6 months post-surgery, that they see their psychiatric care team more frequently, that medications are monitored, and that we should also be assessing for new onset substance use or abuse. And finally, I recommend collaborating with the surgical team whenever possible to discuss these risks. Now I'm going to shift to the last area I'm going to discuss in terms of psychiatric risks, alcohol and substance use. There is an increase in problematic alcohol use post-surgically. The chart that you're seeing, just to orient you, we have years on the x-axis and prevalence on the y-axis. The blue line is regular alcohol consumption, and the red line is alcohol use disorder symptoms. You can see both of those increase pretty dramatically post-surgically. Of note, this study was conducted only in patients who underwent gastric bypass. But we also see more modest increases in both illicit drug use, the green bar, and also substance use disorder symptoms, the black line. Some follow-up work is done looking at both patients who underwent sleeve gastrectomy and Roux-en-Y gastric bypass. They followed the patients for 8 years, that is the x-axis, and on the y-axis here we have mean audit scores, which is a measure of alcohol symptomatology. The black lines are the surgical cases, and the orange lines are the non-surgical controls. What you can see is that after year 5, patients who undergo Roux-en-Y gastric bypass had higher alcohol use disorder scores compared to the non-surgical controls. We didn't see this effect in sleeve gastrectomy. So what we know about alcohol use disorders is that regular alcohol consumption increases, and so does problematic drinking. This is more prominent in patients undergoing gastric bypass. And although, yes, it is a risk if the patient was a heavy drinker before surgery, 45% of patients with alcohol use disorders are presenting with new onset. Risk increases with time from surgery. Often patients are recommended not to drink in the first 6 to 12 months. They haven't really started drinking until after that first year. And notably, although patients assure us that they're going to change their alcohol use post-surgically, post-surgical drinking rates are pretty similar to pre-surgical rates. Risk factors for problematic alcohol use. Pre-surgically, we've identified that male gender, younger age, smoking, and previous alcohol use disorder, as well as regular alcohol consumption, all increase the likelihood that patients can have problematic drinking. Post-surgically, worsening mental health, becoming single, meaning romantically, and onset of smoking, alcohol consumption, or illicit drug use. So what's driving this problem? So one factor may be altered pharmacokinetics. We know that the rapidity with which a substance reaches the brain may affect its addiction potential. And what we see is reduced time to peak blood alcohol concentration observed in patients who have undergone Roux-en-Y gastric bypass, and to some degree those who have undergone sleeve gastrectomy. It's less consistent in those studies of sleeve patients. So blood alcohol concentration peaks so rapidly after patients undergo surgery that systemic availability of alcohol is akin to intravenous administration of alcohol. So it's going pretty fast. Again, it may be related to gut changes that may be making patients more susceptible to alcohol use disorder. Some researchers have had rats undergo gastric bypass, and they find that they uptake alcohol more readily after surgery compared to rats that have not, and that administering a ghrelin 1A receptor can attenuate this effect. So maybe something with gut changes. And then it may be that there are underlying common genes that predispose individuals to overeating and obesity and alcohol use disorder that may be operating. Substance opioid use in particular is also affected after bariatric surgery. And this is likely related to chronic pain, which is quite common in patients who undergo MBS. Over half report arthritis, and 88% report chronic muscle pain that interferes with their daily activities. And of course, having chronic pain is associated with both over-the-counter and prescription pain use. Prevailing wisdom would suggest that after bariatric surgery, patients are reducing their opioid use, but this is not what the data show us. So on this graph, we have mean daily morphine equivalents on the y-axis and time, both pre-surgery and then divided with that blue line at the time of surgery, and then 3 years post-surgery. And what you can see among those who were using opioids chronically before surgery, they're raising their mean daily morphine equivalent levels over time. Amongst patients who were opioid naive prior to surgery, that lower black line, we're also seeing an increase there overall. So this is of concern. What we know is about 6.3% of patients will develop a new onset of chronic opioid use, and this is defined by patients being opioid naive prior to surgery and still using opioids 1 year post-surgery. Risk factors are older age, non-white race, tobacco use, having a history of a mood disorder, undergoing bypass as opposed to other bariatric surgery procedures, and having a post-operative complication. It doesn't necessarily affect weight loss outcomes if our patients are developing new onset opioid use disorder. However, they do have, of course, poor psychological well-being, higher rates of depression, higher rates of body dissatisfaction post-surgically. And there's been a movement to address this, not just in bariatric surgery. I think everyone's trying to figure out how to reduce new onset chronic opioid, or the use of chronic opioids. And it was common to routinely prescribe patients who underwent bariatric surgery with opioids at discharge. More recently, we're implementing different kinds of protocols, not that we as a field, the royal we, if you will. And one of these is called the Bariatric Enhanced Recovery Protocol. Intravenous acetaminophen is administered both perioperatively and postoperatively. Patients are given a lot of education about pain, that the goal, of course, is not total absence of pain, but management, good management of pain. And opioids are considered a third line of pain management after, like, tramadol, for example. And this recovery protocol has been quite effective. It was associated with a decreased length of stay. Patients had reduced levels of opioid prescribing at discharge, so only 9% after this protocol compared to the 100% before. And notably, there were no differences in post-surgical complications, which is pretty important. Here at Johns Hopkins, I know we are using a similar protocol, but I think maybe nationally or globally, there's still a lot of concern that if we are discharging patients without opioids, that doctors are going to get a lot of phone calls and have to do a lot of management. So I think there's still a lot of room to grow with this overall, but it's, I think, definitely a move in the right direction to reduce the problem of new onset opioid use. So in conclusion, I hope I've demonstrated that although metabolic and bariatric surgery is an effective weight loss intervention, there are some concerning post-surgical psychiatric risks that we should be paying attention to. We need to carefully assess for eating disorders, mood instability, suicidality, and substance abuse and use post-surgery. And I think as psychiatric care providers, we need to be prepared for post-surgical pharmacokinetic changes that may impact medication absorption. Thank you for your time.
Thank you, Dr. Schreyer. That was really great. Wonderful overview of what I realize is a pretty complex area. I guess, you know, what it made me think about is the perioperative pain clinic and this idea that those folks have that you need to take a subset of people going into surgery and really begin working with them ahead of time in order to minimize bad outcomes afterwards. Is that something that would make any sense here, or is that what you're already doing? You're doing pre-op evals, I know.
Yes, we're doing pre-op evals. We don't typically talk about pain management in the hospital at those
Oh, no,
preoperative evals.
I'm not so much referring to the pain issue itself, but this concept that you sort of identify a subset of people going into surgery who are higher risk people and begin working with them with the idea of working before and after.
Yes, so in the pre-surgical period, we are definitely identifying patients who are at higher risk of disordered eating, So not just chronic pain, of course, disordered eating, mood instability. And we often see those patients for a period preoperatively, and then often, a lot of times, I'm checking in with them postoperatively. The amount of time varies depending on the complexity of the patient. Sometimes they see me at 3 months, and they're like, I'm great, see you if I need you. And it's really just to let them know that if we spend a lot of time providing education about these risks that I talked about during that evaluation, so that the patients kind of know, and then I give them specific ideas of what they can do. So obviously, if they have eating problems, they should come back to myself or Dr. Coughlin. If they're having mood instability pre-surgically, we have a plan in place, right? I've tried to connect with their team in some way to make sure that that's all happening.
Yeah, so it sounds like what you've got going now is very much akin to that, to that concept. Other folks have questions? Dr. Nestat?
Sure. So the
Just
timeline.
do a kind of a quick summary of the question.
I'm sorry. So the question is, A, what is kind of the timeline of when suicide is happening? That there is a researcher, David Lester, who found that individuals who had their hearing or sight restored kind of had blamed it an external problem, and then when all their problems didn't get better, were kind of like struggling. And whether or not anyone has interviewed patients who attempted suicide to determine if this hopelessness or hopefulness was a part of the presentation. Okay, so the answer to the timeline question is that about 70% of the suicides are completed in 3 years, and it's usually between 18 months and 5 years. I do not know if anyone has interviewed patients who have attempted suicide. I did not read a qualitative study, but now I'm quite interested. I do think that there is something to that, not just for patients who undergo bariatric surgery, but I often tell my patients, the surgery or weight loss in general is not going to solve your problems, but there is a very strong belief that if I lose a lot of weight, everything's going to be better. And the things that are going to be better are that you're going to move more easily. But also, sadly, people are going to be kinder to you. That is the reality of the world that we live in, because weight is very stigmatized. So I do think that there is a possibility that that is playing a role, that they believe that things are going to be better, and then maybe not everything is, and then they kind of focus on themselves.
Interesting. Great. Thanks. Other folks? Dr. Moran?
We are really trying for the latter.
Repeat the question.
Repeat the question. The question is, we are engaging patients pre-surgically. Are we trying to screen them out, or are we trying to engage them in the process? And the answer is, we're really trying to do the latter. The goal of the pre-surgical psychosocial evaluation is not to exclude patients. My goal is always to help patients move towards surgery. But not everybody is open to the idea that at the time of evaluation, they have serious risk factors that make me suggest that they are not ready at that point to move forward with surgery, and I would like them to, for example, meet with a psychiatrist or a psychiatric care provider and do a trial of an SSRI to see if we can improve that mood, or to have a course of cognitive behavioral therapy for binge eating disorder. So if the patient is open, and we do our best to engage them and move forward, but I think it's also the case that I know that patients get quite angry with us and then say, forget this, and go down the road to another hospital, and that now they know what to say, if you will, to not experience the same thing. But I think we are pretty effective at engaging. And I will say that even if patients are kind of reluctant to make these changes, the vast majority at the end of treatment will tell me they are so happy they did it because they are so much better prepared and ready for surgery. It's a big deal to do this.
Thanks. Dr. Gorda.
So the question is, Dr. Guarda was unaware of the changes with opioid use increases after surgery, and she's wondering if whether there's been research done on cannabis that may be affecting outcomes. And that is a very hot topic within the field of MBS right now, and is often the subject of debate at conferences. The answer is the data are really unclear at best, right? So a little bit of it shows that perhaps cannabis use can be associated with loss of control eating because patients are feeling less inhibited after using cannabis post-surgery. There's nothing that indicates it's associated with weight loss outcomes, or not clear and convincing evidence, I should say, that it's associated with weight loss outcomes. One thing that we do kind of talk about with our patients is that smoking cannabis, any kind of smoking, can impair wound healing, so we want to help them move away from that pre-surgically. And so a lot of what I do is education with the patients about the potential risks. And if I do have someone who's using regularly, sometimes the surgeon will say they have to stop using for a period of 6 weeks before surgery. Other surgeons kind of shrug and say, if they're not smoking, I'm okay with it. So a lot of psychoeducation and kind of following the surgeon's lead on what they prefer at that point.
Interesting. Other folks? I have another question, which is, I'm not sure I know, and maybe you said this at the beginning and I wasn't paying attention. What's the overall success rate of these surgeries? I guess I had been under the impression that the success rate was not quite as high as one would like.
So one of the first slides I showed 20-year outcomes for the gastric bypass, which is the surgery we have the longest data on, really.
Yes.
And the majority of patients do maintain a good amount of the weight that they've lost and see sustained remission of type 2 diabetes and other kinds of comorbidities. But weight regain is kind of the rule. It seems increasingly that our bodies are set up. In fact, there was a really interesting paper by, I think it's Kevin Smith. He created a formula that kind of predicts how quickly patients will regain their weight loss depending on the kind of intervention used, whether it was behavioral weight loss, some of the anti-obesity medications we're seeing, or surgical interventions.
But when you say the weight gain happens, you mean in a substantial minority that happens?
No, some weight regain happens in most patients. So a good outcome is if they're gaining maybe somewhere between 10 or 20 pounds over the lifetime with more weight. But it is typical for patients to regain some of the weight they lost.
Okay, got it. Thanks.
Yeah.
Other questions? Okay, with that we will wrap up. Thanks so much, Colleen. That was wonderful.